Acute lower GI bleeding. It's one of those things that's a daily reality in emergency medicine. It can range from a minor annoyance to a straight-up life-threatening hemorrhage. And honestly, the difference often boils down to just a few key decisions. So today, we're going to break it all down, a complete clinician's guide to navigating this really complex, high-stakes problem. Right off the bat, let's just put the stakes on the table. Now, thankfully, most of these bleeds do resolve on their own. But the overall mortality rate is still somewhere between 2 and 4%. Think about that. For every 25 to 50 patients you admit with this, one might not make it. And that's exactly why having a clear, structured approach is absolutely non-negotiable.
So here's our roadmap. It's pretty straightforward. We'll kick things off with the basics of what LGIB even is. Then we'll dive into the key causes and how to assess a patient. From there, we'll cover triage and diagnostics, and then wrap up with a super critical topic, how to manage patients on blood thinners.
Okay, first things first, let's make sure we're all on the same page by just covering the fundamental definition and the scope of this problem.
So what exactly are we talking about here? Well, an acute lower GI bleed is defined as any blood loss that comes from a source distal to the ligament of Treitz. You can just think of this ligament as the anatomical fence that separates the upper and lower GI tracts. Anything south of that fence, that's our turf. And it accounts for a solid 20 to 25% of all GI bleeding we see.
All right, now that we know what it is, let's look at what's causing it. Figuring out the source is absolutely key to managing it, so let's get to know the usual suspects.
By far, and I mean by far, the most common culprit is colonic diverticulosis. These are just little herniations or outpouchings in the colon wall. They're incredibly common, especially as people get older. And while most of them are totally harmless, they are the undisputed #1 cause of significant lower GI bleeding.
So, you might be wondering, how does this harmless-looking little pouch cause a major hemorrhage? Well, the mechanism is actually a fascinating three-step process. First, the lining of the colon bulges out through weak spots. Now, these weak spots are often right where blood vessels penetrate the muscle wall, which, you guessed it, exposes those arteries at the base of the pouch. Then, over time, injury to these exposed vessels can cause them to rupture, leading to what is often a sudden, large volume, and completely painless bleed.
Now, beyond diverticulosis, there are really 3 other major players you got to keep in mind. You've got angiodysplasia, which are basically fragile, malformed blood vessels. Just think of them as weak points in the plumbing. Then there's ischemic colitis, where bleeding is caused by a lack of blood flow to the colon. And the key here is that this one usually comes with pain. And finally, of course, hemorrhoids, a super common cause of more minor bleeding right from the end of the line.
Okay, let's put this into practice. When a patient shows up with a suspected bleed, your initial assessment is absolutely everything. These are the crucial first steps you have to get right.
The classic presentation is hematochezia, painless bright red blood. But the real clues to how severe it is come from the systemic symptoms. Are they dizzy, fatigued? Did they faint? These are all major red flags for significant volume loss. Your history taking is like a detective story. You have to ask about blood thinners, NSAIDs, any prior bleeds. Every single answer helps you build your case.
The physical exam is all about one thing, assessing hemodynamic stability. We check orthostatic vital signs, measuring blood pressure and heart rate lying down and then standing up. A big change tells you the patient is volume depleted. And here's a quick, powerful tool, the shock index. Just divide the heart rate by the systolic blood pressure. If that number is greater than 1, that's a huge warning sign of instability. And a digital rectal exam, it is non-negotiable. It's essential for finding local causes and just confirming that there's active bleeding.
Okay, once you've assessed the patient, the next steps have to happen immediately. You need to stabilize them, stratify their risk, and then decide on the right level of care.
This is the fundamental question you have to answer, and you have to answer it fast. Is this just a minor, self-limited bleed that can be managed as an outpatient? Or is this a major bleed that needs admission, resuscitation, and urgent intervention? How do you make that call objectively? Well, the answer lies in clinical risk scores, and the Oakland score is a fantastic tool for exactly this. It uses 7 simple variables you can get right at the bedside: age, vitals, hemoglobin, to predict the risk of a major bleed. And it's logical, right? Things like older age, a faster heart rate, and lower blood pressure all add points and jack up the risk. And here it is, the magic number, 8. An Oakland score of 8 or less identifies a patient with what we can call a minor bleed. This is so powerful because it gives us the confidence to safely send them home from the ED for outpatient follow-up. That frees up a bed and a ton of resources. But a score above 8, that means admission. It's that simple.
Okay, so our patient has a major bleed. They're admitted. Now what? We have to find the source. This brings us to a huge decision point in diagnostics, choosing the right path forward. Scope or scan?
You know, everything that follows hinges on the answer to this one single question. Is the patient hemodynamically stable? In other words, after our initial resuscitation, is their circulation holding up or is it failing? Their vital signs, their response to fluids, that is what dictates the entire diagnostic algorithm.
So, for that unstable patient, the one with ongoing, severe bleeding, we face this critical dilemma that even the experts debate. Do we go straight to an endoscopic procedure, or do we get a scan first to try and localize the bleed?
And yeah, this is where it gets a little tricky because the major international guidelines don't actually agree. Here in the US, the ACG suggests an upper endoscopy first. The thinking is that up to 15% of what looks like a lower GI bleed is actually coming from an upper source. But over in the UK, the BSG recommends a CT angiogram first to get a rapid bird's-eye view of the entire vascular system.
So, how do we resolve this? Well, in the real world, the answer often comes down to logistics. As the source material points out, the decision has to be individualized. Do you have an interventional radiology team ready to go for a CTA and embolization? Or can your on-call endoscopist get a scope in their hands faster? A lot of the time, the best test is simply the one you can get done right now. Let's tackle one last, really crucial area. More and more of our patients are on blood thinners, and when they bleed, it creates this high-stakes balancing act that absolutely requires a coordinated, team-based approach. Managing these patients really boils down to three key principles. First, team up. This decision cannot be made in a silo. You need GI and cardiology at the table, weighing two competing disasters, the risk of bleeding to death versus the risk of having a catastrophic stroke or heart attack. Second, in a major bleed, you hold the agents and you consider reversal. Finally, you restart wisely. For a patient taking aspirin because they've already had a cardiovascular event, the evidence is crystal clear. Get them back on it as soon as possible, usually within 5 days. So, after all that, what are the absolute key takeaways? If you remember nothing else, remember these three things. Number one, hemodynamic stability is everything. It drives triage, resuscitation, and the entire diagnostic pathway. Number two, remember that diverticulosis is the most common culprit and it almost always presents without pain. And number three, managing blood thinners is a team sport. It requires a careful balance of risk and benefit for every single patient.
And that leaves us with a final thought to chew on. We know our population is getting older, and the use of anticoagulants is just skyrocketing for things like atrial fibrillation. This means the number of cases and the complexity of managing lower GI bleeding is only going to go up. The question for all of us is, how will our systems, our teams, and our technologies evolve to meet this growing challenge?